respected Dean Dr. Sudhir Gupta sir and our Professor and Head Dr. Kamal Madam for giving us this opportunity. Today's topic is skin biopsy interpretation and few psoriasiform and vesiculobullous lesions. I shall be speaking on skin biopsy interpretation, a simplified approach to the stratified challenge. Yes, I say that this challenge is stratified because at every level, starting from clinical, technical and interpretational, every level there is a challenge. I shall be speaking under these headings: introduction, advantages of skin biopsy, different perspectives of dermatologist and pathologist towards skin biopsy, various difficulties encountered, pattern analysis, how to frame a biopsy report of skin biopsy, do's and don'ts in skin biopsy. Skin biopsy, if properly performed, not only gives proper diagnosis or definitive diagnosis, but it guides to therapy and sometimes it may even remove cosmetically unacceptable lesions. Skin biopsy is unique because the lesion to be biopsied can be directly viewed. It can be performed in critically ill patients with minimal risk. Despite various technical advances, skin biopsy still remains the gold standard for the diagnosis of cutaneous lesions, especially inflammatory dermatosis. Inflammatory dermatosis are extremely common and form a major bulk of skin OPD, but their diagnosis is challenging both clinically and histologically. Pathologists and dermatologists both have different perspectives for skin biopsy. Dermatologists are usually not willing. Most of the times, dermatologists are not willing to go for biopsy because we can see various causes for that. Most of the times, the biopsy findings are inconclusive. Rather than guiding to therapy, they may add to confusion. Such reports are often descriptive and the information given in this report is not meaningful. It does not solve any purpose. Now, pathologists also have their own perspectives for skin biopsy, and most important is that the unending and confusing terminology which all of you can agree. Many of the entities have overlapping features in etiologically different conditions can show similar morphology. You can take an example of lupus vulgaris, tubercular leprosy, granuloma annular, sarcoidosis. All of these are granulomatous lesions and more or less similar features are seen in the dermis. But etiologically they are different and their treatment is different. So it really becomes very critical to point out what is the actual diagnosis. Similarly, in the same lesion at different stages, different morphology is seen, which makes it more confusing. Lack of clinical details further adds to confusion. And it is because of this, pathologists are not eager to report skin biopsy. Now, how we can solve this problem? An adequately taken skin biopsy, properly sampled with complete relevant clinical details, including all possible differential diagnosis, is expected from a dermatologist, whereas a well-trained pathologist with proper knowledge of dermatology, interest, concern, pros and consequences of offered diagnosis is what is expected from a pathologist. Then best results can be obtained. A number of techniques are available for skin biopsy: shave biopsies, scraping, sponge biopsy, excisional or incisional. The selection of biopsy technique is most crucial in maximizing the sample yield and increasing the chances of getting either a definitive diagnosis or a meaningful differential diagnosis. Dermatologists are supposed to know the inherent strengths and weaknesses in all the standard available techniques. And the selection of the technique depends on it depends on the type and size of the lesion also, but it is mainly based on the experience and the circumstances relating to each case, while keeping in mind the aim of providing best possible sample. Most popular technique used for inflammatory dermatosis is punch biopsy. Punches are available in different sizes and their selection depends on the type of the lesion, size of the lesion, and also age of the patient. All the relevant clinical examination findings, including distribution pattern of the lesion, whether it is single or multiple, generalized or focal, symmetrical or asymmetrical, with or without systemic involvement, and all other clinical details including age of the patient must be informed along with the sample. In general, earliest lesion showing maximum fully advanced changes should be chosen for biopsy. Tiny lesions like less than 4 millimeter and early vesicle should be sampled intact. For vesiculobulous lesions, early lesions are preferred. Lesions with secondary changes like fissures, ulcerations, excoriations are avoided because primary pathological process may be obscured with this. Lesions with poor healing characteristics, areas of poor healing characteristics are to be avoided. If lesions are multiple and if differential diagnosis is broad, then taking sample from multiple sites reduces the sampling error. Cosmetically important areas like face should be approached with caution. And most important thing is that dermatologists must be aware of the limitations of pathologists. After all, they have whole 5-foot patient with them with all possible clinical information, and we have only 5 millimeter with all information provided by them only. So if this is all followed, then better results can be obtained. There are certain things which need to be followed by the pathologist also. A pathologist is supposed to have knowledge of microanatomy of the skin, including its physiological variations and functional significance. Otherwise, skin on the palm and soles would be labeled as hyperkeratotic. He is supposed to know for what the biopsy is taken and what will be the consequences if what report is given. He should be aware of biological behavior of common inflammatory dermatosis and frequently used terminologies in clinical practice, in dermat practice mainly. It is really very difficult to remember all these names in dermatology, but we have to apply some knowledge, some sense, and correlate it clinically. For example, the term pityriasis means shedding of dry scales. So it is white in alba, red in rubra and rosea. So if it is rubra and rosea, that means red lesions are seen. So we are expected to get congested capillaries or hemorrhage or extravasation of RBCs there. The term epidermolysis bullosa is self-explanatory. It is a bullous lesion which is characterized by lysis of epidermis. The term prurigo can be linked with pruritus. So there is pruritus, that means we are going to see some eosinophils there. If it is nodule forming, then it is prurigo nodularis. The term erythema multiforme, again it shows varied morphology. So any possible combination can be seen there in that erythematous lesion. The term inflammatory linear verrucous epidermal nevus appears so long, ILVEN, which is commonly called as ILVEN. So basically this is a epidermal nevus, which is verrucous, having verrucous surface. Linear is for clinical appearance of the lesion, and the term inflammatory means secondary inflammatory changes are seen there. So it is basically an epidermal nevus with secondary inflammatory changes. Thus we have to correlate clinical and pathological, then we can solve this problem easily with interest. Now coming to actual pattern analysis. Pattern analysis is the best way to report skin biopsy. It avoids confusion, it narrows down the diagnosis. For this, we have to start with scanner view appearance. Here, the scanner view appearance is based on the appearance due to collection of inflammatory cells in particular regions. Many systems of pattern analysis are available. The most widely used and accepted standard method is A.B. Ackermann's criteria. Here, as per scanner view, inflammatory dermatosis are divided into 9 major basic patterns. This is based on the pattern of inflammation, their localization. Maybe in the superficial or deep dermis, the inflammation can be perifollicular, periadnexal, perivascular, interstitial, or it may be involving subcutaneous. So the density of inflammatory infiltrate can be appreciated on scanner view. Further subtyping is done under high power magnification. These are the 9 basic patterns: superficial and deep, superficial perivascular dermatitis, superficial and deep perivascular dermatitis, nodular and diffuse, vasculopathic, intraepidermal, vesicular and pustular, subepidermal vesicular, folliculitis and perifolliculitis, fibrosing dermatitis and paniculitis. Now here it appears very tedious, but we can see it in simplified way. Here is the here we can see superficial perivascular dermatitis, where inflammation is seen mainly in the venules in the superficial part of dermis. In the second pattern, we can see that the inflammation is extending into deeper part of the dermis. The third pattern is nodular and diffuse dermatitis. Now here, the intensity of inflammation is more, it is dense. There is formation of nodules. These nodules later on coalesce together and form diffuse. So the third pattern of nodular and diffuse dermatitis include all granulomas, abscesses, and inflammatory infiltrate varies in that. So depending on that, further classification or subcategorization is done. Fourth pattern is vasculopathic dermatitis. It is limited for those lesions which show changes in the vessel wall, mainly disruption of the vessel wall and presence of fibrinoid necrosis also. The fifth and sixth pattern is for separation or cleavage type of dermatitis. Depending on the level, they are further subdivided. Next pattern, seventh pattern is folliculitis and perifolliculitis. So inflammation is seen in and around hair follicle. Eighth pattern is fibrosing dermatitis, characterized by excessive deposition of collagen in dermis, and ninth pattern is paniculitis, inflammation in the subcutaneous fat. Now this was diagrammatic representation. Now we can see actual biopsy slide. Here we can appreciate that the inflammatory infiltrate is limited to superficial layers only, whereas here the dark blue colored inflammatory zones are seen extending into deeper dermis also. Here the intensity of inflammation is more and there is formation of nodules. So this is nodular dermatitis, and these 2, 4 and 5 are diffuse dermatitis which show top heavy or bottom heavy type of infiltrate. Here it is top heavy infiltrate, whereas here it is bottom heavy infiltrate. In this pattern, vasculopathic dermatitis, the intensity of inflammatory cells is appearing less. It is because of increased eosinophilic content due to fibrinoid necrosis of the vessel wall. That is why blue color is appearing less. Many times, high power examination becomes essential to rule it out from perivascular dermatitis. Now, the upper 3 figures indicate cleavage or separation type of dermatitis. Here, depending on the plane of cleavage, whether it is subcorneal, whether it is intraepidermal, it is divided into pattern 5th and 6th. So, this 6th pattern is subepidermal. Subepidermal, vesicular and pustular dermatitis. In the 7th pattern, inflammation is limited to follicle and perifollicular region. In the 8th pattern, again increase in the collagen or fibrous tissue in the dermis. And last, ninth pattern is paniculitis. We can see that the inflammatory infiltrate is involving subcutaneous fat here. Further subcategorization is done using minor criteria. Once it is decided that which pattern it is, then subcategorization is done. For this, top to bottom approach is used. Look for the changes in the epidermis, changes in dermoepidermal interface, changes in dermis, and involvement of subcutaneous tissue. Further categorization depends on the type of infiltrate, whether there are lymphocytes, neutrophils, eosinophils, histiocytes, mast cells, epithelioid cells, or granulomas. Now coming to changes in the epidermis. Epidermis may remain normal, so it is unremarkable epidermis. It may be thin with loss of fatty ridges, as we can see in morphia or lepromatous leprosy. It can be hyperplastic, and that hyperplasia can be regular, as called as psoriasiform, or it can be irregular hyperplasia. It can be spongiotic, that is intraepidermal presence of vacuoles and edema in between keratinocytes, and vacuolar, that is basal cell layer vacuolar change. Now further details can be seen starting from keratin layer. Normal keratin appearance is like basket wave pattern called as orthokeratosis. So it shows 2 to 3 layers depending on the physiological variations. Hyperkeratosis is increase in the keratin layers. It can be compact hyperkeratosis. It may be focal, or it may be alternating with normal to compact. It may be located only over papillary epithelium, as seen here. Here dense compact hyperkeratosis, or it may be alternating with orthokeratosis. The alternating hyperkeratosis can be vertical alternating, or it can be horizontally alternating. Each of the finding has a significance. In the superficial keratinous layer, sometimes we may get fungal elements. So budding yeast forms can also be seen. So look for fungal elements, and if doubt, then we can go for special stains also for confirmation. Parakeratosis is retention of nuclei in superficial keratinous layer. It is inversely proportional to the granular cell layer thickness. Parakeratosis can again be uniform, it can be focal, it can be alternating with hyperkeratosis. Here we can see alternate areas of hyperkeratosis, parakeratosis. Again, it can be horizontally alternating, it can be vertically alternating also. We can look for presence of entrapped RBCs within parakeratotic layer. Look for presence of neutrophils and other inflammatory cells in the parakeratotic layer, because it has diagnostic significance, especially for Munro's microabscesses in psoriasis, or in follicular infundibulum, or in epithelial invagination. Parakeratotic plug may be seen, called as coronoid lamellae, as in case of porokeratosis. So each of these finding is very important and has got some diagnostic significance. Follicular plugging is hyperkeratosis within hair follicle. This is seen in DLE, but not specific of that. Sometimes we may get parasite inside hair follicle, that is Demodex follicularum. Normal granular cell layer thickness is variable depending on the site, and it is directly proportional to the keratin layer and inversely proportional to parakeratotic layer. So hypergranulosis can be uniform, it can be focal, or it can be wedge shaped, as in case of lichen planus. Reteridges. Number of appearances of reteridges can be seen. This is normal appearance. This is normal epithelium showing orthokeratosis and normal reteridges. There can be flattening of reteridges. They can be showing regular elongation, or they may get fused with increase in the pigment at the base of reteridges, or they may be elongated, thin. They may be irregular, fused, They may be regular with follicular plugging or they may be with pointed ends. Each of this has diagnostic significance, so we have to note it down and mention during our report. In interface dermatitis, maximum changes are seen at dermo-epidermal junction. Here we see vacuolar change at the basal cell layer. There is destruction of basal cell layer, which is usually autoimmune in origin. It is associated with lymphocytes surrounding these cells. Along with basal cell layer, melanocytes are also engulfed and they are also destroyed, and they are taken up by dermal macrophages, and what we see is increase in the melanophages in the dermis. Due to destruction of these pigmented cells in dermis, such lesions clinically appear as hypopigmented patches. So we have to correlate these findings with clinical features also. Now coming to individual reaction patterns in short. Lichenoid reaction pattern is very common and in general characterized by irregular hyperplasia of epithelium, which I have just now described, basal cell layer damage, sawtooth rete ridges and band-like dermal infiltrate. Prototype conditions of these are lichen planus, lichenoid rug eruption and lichen nitidus. It is not possible to go into details of each condition. I will just mention the patterns. In this, civet bodies are also commonly seen. They are nothing but apoptotic keratinocytes. They are also called as colloid bodies, and they appear as intensely eosinophilic shrunken cells with pycnotic nuclei. So they can be seen at variable level of epidermis, and usually they are surrounded by lymphocytes. Next pattern is psoriasiform reaction pattern characterized by regular elongation of rete ridges, increased mitosis in the epithelium, papillary dermal edema, para and hyperkeratosis. And prototype conditions are pityriasis rubra pilaris, lichen simplex chronicus and psoriasis. Details of this will be discussed in subsequent lecture. So I will shift to next pattern, that is spongiotic reaction pattern. This is characterized by intercellular edema and increase in the spaces between keratinocyte. The type of infiltrate in between these can be neutrophilic, it can be eosinophilic. Depending on that, they are classified as neutrophilic spongiosis, as seen in pustular type of psoriasis or Swift syndrome, or eosinophilic spongiosis as seen in allergic contact dermatitis and atopic dermatitis. The next two patterns, that is separation or cleavage type of dermatitis, include subcorneal or intraepidermal type of cleavage, and their classification is based on the plane of cleavage and type of infiltrate. Clinically also, information is very important whether they are tense or not. This will be again discussed in next vesiculobullous diseases. So type of infiltrate is very important here. Skin biopsy is gold standard for the diagnosis of cutaneous vasculitis. The varied clinical appearances of cutaneous lesions in vasculitis arise from the extent of involvement and the type of vascular bed affected. The skin biopsy involving subcutis and taken from earliest most symptomatic red or purpuric lesion is crucial for obtaining maximum diagnostic yield. Disruption of small vessels with presence of fibrinoid necrosis or inflammatory cells and nuclear debris within the vessel wall is very diagnostic of vasculitis. The histological findings along with other important clinical data and ANCA positivity data, immunofluorescence studies and other clinical information helps in arriving at more accurate and precise diagnosis of cutaneous vasculitis or leukocytoclastic or neutrophilic type of vasculitis. The folliculitis and perifolliculitis are characterized by inflammation in and around hair follicle. It can be superficial or deep, and it depends the type of infiltrate depends on the stage of the disease. It may be infectious or non-infectious, and it may extend into surrounding tissue even up to reticular dermis. In fibrosing dermatitis, excessive collagen deposition is seen within the dermis. Various prototype disorders are linear scleroderma, sclerosis, and morphia. So these are usually, if it is inflammatory injury, it precedes granulation tissue. But in autoimmune diseases, it is sclerosis and it will not precede granulation tissue. Special stains like Masson trichrome can be done for confirmation of this. The last pattern is paniculitis, which shows involvement or inflammation of subcutaneous fat. It can be further divided into septal or lobular. There is a separate algorithm for classification of paniculitis. So it can be with or without necrosis, with or without granulomas, with or without vasculitis, and very commonly seen condition is erythema nodosum leprosum, erythema induratum. All these conditions are prototype conditions of showing paniculitis. Apart from these major and minor patterns, we have to look for changes in the dermis. Look for presence of mucin, as in case of DLE and granuloma annular. We can go for special stains like Alcian blue. Look for presence of mucin, amyloid, especially in papillary dermis. Presence of hyaline, foreign body, edema, debris, and pigment, melanophages. So all these things should be looked for, and if present, it should be noted down. So an ideal report of inflammatory dermatosis should include 3 parts. It should start with microscopic description, which should mention adequacy of the biopsy, quality of the section and staining, and which special stains were studied. Then it should be followed by top to bottom findings, positive findings, starting from keratin layer up to fat, subcutaneous fat. What are the positive findings? The next part is the comments part, and this is the most important part. Here, the result of special stain should be mentioned, and it should also include negative findings. Unfortunately, this is the part which is, although most important, which is most often missed, and most of the pathologists do not comment on negative findings. So if the clinical diagnosis is vasculitis, and in spite of serial sections, we are not able to see any fibrinoid necrosis or disruption of vessel wall, it is essential to mention that these changes are not seen, so that dermatologist can take another biopsy or think of other differential diagnosis. The third part is diagnosis. When possible, it is important to provide a specific histopathological diagnosis. Suppose clinical diagnosis is lepromatous Hansen's and we are seeing FF is positive, then we can happily sign the report as FF positive and diagnosis is lepromatous Hansen's. But what if it is not positive? If we don't see histiocytes, we have to mention that histiocytic infiltrate is not seen. That will definitely be helpful for the dermatologist, that they can think in other direction also. But if it is not possible, it is acceptable to provide a descriptive diagnosis if the findings are not conclusive. Now, what does this descriptive diagnosis suggest? Remember, absence of specific diagnostic features is not synonymous of chronic non-specific dermatitis. So, a pathologist should never write down the report as chronic non-specific dermatitis. This report is very frustrating for dermatologists because they will never sample any non-specific dermatitis like lesion. If we are not able to mention the negative findings, what is not correlating, what are positive findings, we have to write it in comment so that another sample can be taken. So the comment section of the report gives meaning to the descriptive diagnosis, and the comment should include negative findings, reaction pattern seen. So what was the reaction pattern, whether it was spongiotic pattern, psoriasiform pattern, lichenoid pattern, and additional features. Even though suspected clinical diagnosis is different and we are seeing something different, then we have to mention it in the report. Try to opine based on your experience. We can suggest other methods like spatial stains and correlation with immunofluorescence, ANCA positivity or IHC. Such things can be suggested if it is not conclusive. And most often, we forget to use one more important tool, and that is telephone or WhatsApp. So if we are not convinced about clinical diagnosis or we have some doubt, we can directly call our dermat friends. And remember that a good relationship with dermatologist is vital for successful practice for any pathologist. And it really makes a lot of difference. What are the advantages of algorithmic method? It can be applied to every inflammatory dermatosis irrespective of whether cause is known or not. If specific diagnosis is not reached by pattern analysis, major categorization leads to narrowing down the differential diagnosis by exclusion. There are certain limitations, like in few cases, histological features may not correspond to those of any of the 9 patterns, or few lesions may show more than one basic pattern. So that is one of the limitation of this, but most of the times we can narrow down the diagnosis. There are some potential sources of error in skin biopsy. Error can be in sampling, inadequate clinical information, technical errors like improper processing, wrong orientation, sectioning, folds, wrong embedding. The importance of serial sectioning must be understood by a pathologist. See the same section on serial sectioning, how it improves. So we always can give serial section. Sometimes the lesion may not be properly sampled. It is showing only subtle changes or early lesions are sampled, or mixed patterns with obscuring morphology, secondary changes like excoriation and ulceration, or coexistent pathologies. These are the do's and don'ts in skin biopsy. Don't report skin biopsy in the absence of clinical details. Don't report inadequate or crushed biopsy. How can we report such biopsy? It is just impossible to report these biopsies. Don't report without observing serial sections if the findings are not diagnostic, and use special stains whenever required. They are definitely helpful. Undoubtedly, skin biopsy carefully performed is an inexpensive, rapid and effective way to assist definitive diagnosis of a patient's skin lesion. Thank you very much for your patience listening.